Role of Doppler in pregnancy. Doppler velocimetry in pregnancy. It was Christian Doppler who told the principle of Doppler effect, Doppler principle. That is, the velocity, the frequency of the sound wave depends upon the relative velocity, the relative velocity of the observer and the source. So he was Doppler principle, whereas Doppler came into effect 1977. So Doppler has got a high useful in high risk pregnancies. There are mainly what are the indices of the Doppler indices? So systolic peak systolic velocity, end diastolic flow, and systolic diastolic ratio, that is resistance index, pulsatile index. These are the various indices which are seen in the Doppler. There are varieties of Doppler: pulse wave Doppler, spectral Doppler, continuous wave Doppler, color Doppler. So each has its own use in conditions. Now coming to the uterine artery Doppler. Dopplers are not, Doppler velocimetry is not done before 12 weeks. It is heat producing. So before 12 weeks it is not done. So it cannot be done before 12 weeks of pregnancy because heat production is there. So abnormal embryogenesis, it is not, only after 12 weeks. Now uterine artery Doppler. So uterine artery Doppler, the characteristic of uterine artery Doppler is their high resistance flow. Then usually in the first trimester, absent end diastolic flow is there, only systolic flow, peak systolic velocity is there, absent end diastolic, little end diastolic flow, and early diastolic notch. So early diastolic notch is normally seen in pregnancy before 18 weeks, 20 weeks. It is even in non-pregnant also, it is seen diastolic notch. So bilateral uterine artery is taken usually to evaluate this bilateral uterine arteries are taken to significance, to know the whether it is significant or not. Bilateral uterine notch, end diastolic, early diastolic notch. So after 22 weeks, early diastolic notch is abnormal. Early diastolic notch is abnormal. Now this is normal. So this, what is the, during pregnancy, this will change. If this is first trimester, in the second trimester there will be diastolic flow, and third trimester abundant end diastolic flow is there. This is normal. Disappearance of diastolic notch, early diastolic notch, this is normal. In the second and third trimester, abundant diastolic flow in the third trimester. Now what is the abnormal uterine artery Doppler? So persistence of early diastolic notch, then increased peak systolic velocity, reduced diastolic flow, absent diastolic flow. These are all abnormal things, abnormalities. There is a chart, pulsatile index. For example, pulsatile index at 12 weeks, it should be not more than 2. So if the pulsatile index is 4, 5, it should high pulsatile index. So abnormal uterine artery means waveform is high pulsatile index, more than 4, 14 weeks, like that. As pregnancy goes on, it is third trimester, pulsatile index becomes less, 1.2, less than 1, like that. So that according to that flow chart, if the pulsatile index is more than 95th percentile, that is, for example, 12 weeks, the flow chart shows pulsatile index of 1.6. Suppose if it is 4, then it is abnormal. So this plus persistence of early diastolic flow in the second trimester after 24 weeks, it is a predictor of development of PIH, preterm labor, abruption. So what is the flow chart or algorithm? For example, if you the uterine artery Doppler is done at 12 weeks and it shows early diastolic notch and absent end diastolic flow, then less diastolic flow, then it is repeated at 23 weeks. Suppose even at 23 weeks, early diastolic notch is there and diastolic flow is less, so that is the indication for starting of the aspirin. 70 mg of aspirin has to be started, and there should be there should be this one to know whether the patient is developing PIH or IUGR abruption. So this is uterine artery. Uterine artery. Next comes the uterine artery, shows the maternal side of the circulation. So suppose the uterine artery, see, end diastolic flow is increased in the second trimester. This shows that placental blood vessels are opened up, that is spiral arteries and converted, and even up to the muscular layer they are converted into tortuous, so the resistance will less, and end diastolic, abundant end diastolic flow will be there. So this is uterine artery, normal and abnormal, and it is significant in predicting screening for PIH, IUGR, and preterm labor and abruption. Now umbilical artery. Umbilical artery also has low resistance flow. Umbilical artery. So in the first trimester, umbilical artery shows systolic velocity, and in the early first trimester, it may end diastolic flow may be absent. But in second and third trimester, umbilical artery end diastolic, abundant end diastolic flow will be there. End diastolic flow is abundant. Diastolic flow will be abundant. So this is in the second and third trimester. Now abnormalities of umbilical artery. So this is umbilical artery is useful in diagnosing type of IUGR, whether it is symmetrical or asymmetrical, and management. So in symmetrical IUGR, Doppler is umbilical artery Doppler is normal. Normal. It is only symmetrical, so small for gestation. Umbilical artery Doppler is normal. That is how you are this one. Whereas in asymmetric IUGR, umbilical arteries are abnormal. That is, what is abnormal umbilical artery Doppler is reduced diastolic flow, absent diastolic flow, and reverse diastolic flow, depending upon the severity. So this is the differentiate symmetrical IUGR from asymmetrical. And management. You see, management. So umbilical artery is not useful for screening of IUGR, because by the time umbilical artery Dopplers become abnormal, 70% of the placental vasculature is deranged. Whereas to develop IUGR, 40% of the placental vasculature is derangement is needed. So this is not for screening, only for management. Now what is the flow chart for management of IUGR depending upon Doppler? Suppose the Doppler velocity is normal, pulsatile index and other things are normal, only IUGR, then you deliver it as 37 weeks. You deliver the routine monitoring, and if it is same Doppler to be done once in 15 days, and it will be delivered at 37 weeks. Now when will you deliver this thing? At 34 weeks. That is, Doppler is normal, but still you have to deliver it 34 weeks. IUGR is, if there is a static growth, so there is no growth scan is done every week, so there is no growth for consecutive 3 weeks, then it has to deliver at 34 weeks after giving steroids. Or this middle cerebral artery flow is showing brain sparing effect. So these two things will show that even if it is 34 weeks, it can be delivered. Now same thing with when the end diastolic flow is present, only pulsatile index are high. Here also the same, we continue for every 15 days Doppler effect and deliver at 37 weeks. And 34 weeks same, when the 34 weeks, when there is no growth scan for the consecutive 3 weeks. Now comes when there is absence of end diastolic flow or reverse end diastolic flow. Here you continuous monitoring every 3 to 4 days Doppler and decide. See, suppose there is end diastolic flow is absent or reverse end diastolic flow, then pregnancy has to be terminated by 32 weeks after giving steroids. By 32 weeks it has to be delivered if there is end diastolic flow is absent or reverse end diastolic flow is there. Now when you deliver before 32 weeks, 30 weeks, so here when there is ductus venosus abnormal waveform are present, reverse A wave in the ductus venosus, the cardiac also is affected. So here even before 32 weeks, 30 weeks also it has to be delivered, because once the ductus venosus abnormality appears, it's a matter of hours for survival of the fetal survival. So this is the flow chart for IUGR depending upon the umbilical Doppler. Now coming to middle cerebral artery Doppler. So see, whereas uterine artery and umbilical arteries, the waveform will change in duration of pregnancy, trimesters. Middle cerebral artery will be constant throughout pregnancy. It is a high resistance flow. So normally there is systolic flow and a small amount of diastolic flow. What are the conditions which are important for middle cerebral artery? So middle cerebral artery, this one Doppler has two important things. One is diagnosing of anemia, fetal anemia, either it is due to RH incompatibility or twin anemia polycythemia sequence, where they are obliterated by laser anastomotic vessels, where small vessels are left behind. So we only RBCs will transfer from one fetus to the other. So this condition is called as twin anemia polycythemia sequence. So one fetus will be anemic, severe. So here they will do MCA Doppler. So what is the in anemia? So peak systole is high. Normally peak systole is more usually 30 to 40 centimeters. Suppose if the peak systole is 120 centimeters. So hemoglobin is fetal hemoglobin is either 5 or 6, like that. There is a flow chart. So suppose they will flow chart shows, suppose the peak systolic velocity is 60 centimeters, hemoglobin is 7, peak systolic is 80 centimeters, so hemoglobin is 4. So depending upon that, that is a use for middle cerebral artery Doppler in diagnosing fetal anemia. Another is brain sparing effect. So brain sparing effect, the abundant diastolic flow will be there, readjustment of blood flow. So that will be show that there is imminent delivery has to be done. Now suppose if there is a brain sparing effect is seen and later it disappears and reverse wave occurs diastolic, that shows the cerebral edema has occurred and imminent death is there. So these are the two uses of middle cerebral artery. Then ductus venosus. So ductus venosus has got a direct connection with atrium and its pulsatile shows pressure waves in the atrium, cardiac. So what is the use? See, normal Doppler ductus venosus got 3 waves, S, D and A wave. So uses Doppler abnormal is A wave inversion. A wave is reverse A wave is seen in some condition. So Doppler done at 13 weeks, and if it shows Doppler venosus, ductus venosus Doppler seen at 14 weeks, if it shows inverted reverse A wave, then it is cardiac anomalies are diagnosed. Cardiac anomaly in the fetus is diagnosed. Now in the later third trimester, suppose if this is a baby is IUGR having, so if it shows ductus venosus shows inverted inversion of the A wave, then imminent delivery has to be occurred even before 30 weeks. So these are the two views of ductus venosus. Now coming to single umbilical artery. So single umbilical artery is seen in about 10% of the scanning process. So this is usually associated with aneuploidy, like Down. This is one of the soft markers. So aneuploidy, Down syndrome, or high risk for premature labor, IUGR, other things. So single umbilical artery. Now there is another use of Doppler in obstetrics. So this is called as role of Doppler in monitoring indomethacin therapy. For example, there is hydramnios and they are giving indomethacin. So one of the side effect is closure of the ductus arteriosus. So here what they will do is the indomethacin, after starting indomethacin for 3 days, they will Doppler is seen for ductus arteriosus. Doppler is done. Suppose if it has started contracting, so they will stop this Doppler, this drugs. So these are the uses of Doppler in pregnancy.